So good evening to one and all present here today for the amazing webinar on digital mental ecosystem and how technology is changing the face of mental health, psychiatry, and how robotics also plays a key role in the psychiatry department. Today we have eminent speakers from SCARF India, one of the premium association and also organization working towards a wonderful patient engagement activities and also organization to start the telepsychiatry in the rural areas. Today, I would like to invite Padmadevi ma'am for this activity. Thank you, ma'am. Thank you so much for this opportunity for this association and inviting our wonderful speakers today. Over to you, Dr. Avinash, sir.
Well, we have, I think, two very interesting speakers who are going to speak on decoding the digital mental health ecosystem, particularly with a focus on opportunities for mobile health innovators and robotics. Our first speaker is, of course, Dr. Sridhar Vaiteshwaran, who is the Assistant Director and Clinic Consultant Psychiatrist for Dementia Care in SCARF. And he's been part of SCARF for many years. Of course, he's a very known figure nationally, internationally, as far as his work goes. And our second speaker is Mr. D. Koteshwara Rao, who is the Assistant Director of SCARF and a member of the State Mental Health Authority, Government of Tamil Nadu. So I think we will not, keep our audience away. The topic is very interesting. We all know that there's so much of work being done. I think let us hear from the speakers and then we can take up questions as they go one by one. I would invite our first speaker to start. He could share his slides and start. And I think once he finishes, maybe we'll take some questions for him and then the second speaker after that. And that's how we'll proceed. Yeah. Thank you.
So,
Over to you, Dr. Sridhar. Yeah.
Thank you so much, sir. And it's a pleasure to be here. And thanks so much for organizing this meeting, such an important topic during this, changing times. We are literally at crossroads right now. And I think COVID has made it very important that we think about how we use technology and how this will actually influence our patient care in the future. So I must thank the organizers for arranging this meeting and for having us here. And thank you so much, Dr. Disesa, for those kind words of introduction. So to begin with, what I'm going to talk today is about our work in using social robots in dementia care. And primarily, I'm going to talk about a study which we completed recently and published sometime in the middle of this year. So that's going to be the focus. And of course, there are lots of learnings from this and some of the things that can potentially work in future and some of the things which we can not just depend, not just kind of, limit to dementia, but also to, other conditions, including schizophrenia or psychosis and things like that, other long-term conditions. So definitely there is a role. So to begin with, looking at social robots and what are social robots? So social robots are designed to provide companionship to people. So they are supposed to improve social interaction and improve the quality of life of the person with whom the social robot is interacting. And there is a lot of evidence, particularly in dementia, looking at reducing the agitation in people with dementia, and particularly some severe behavioral and psychological symptoms have shown to improve quite significantly, particularly with this. There's a lot of evidence with this particular robotic seal, the picture that you see here on the right top, which is a baby robotic seal, which actually makes some sounds like a baby seal, and which is very soft and furry, and patients really like to touch it. And I've used one before in the UK, and that's a very nice thing to hold in your hands. So that often many persons with dementia like it, and so that has the most evidence base. And of course, there are robotic cats now. There is also a robotic dog, and there is a conversational figure, Eva, which has been tried in Mexico. So there are lots of things which have been going on around in the world. So we did a kind of a scoping review of literature, and we found that we didn't have that many studies from developing countries. Apart from that one study from Mexico, there weren't that many studies from other low and middle income countries. Most of the studies were from Japan, Europe or Americas, and not much from low and middle income countries. So when we looked at what can be done in a low income country, a low resource country like ours, the need for, is there a need for robotic use in India? Now, many people feel that it may not be necessary at this point in time, and they are probably right to an extent. But looking ahead, I think we should be prepared for the future. And we are an aging population, whether we like to believe it or not. In about 30 years, nearly 20% of our population will be elderly, nearly. And in about 100 years, we'll have about 30% to 40% of our population will be more than 60, 65 years of age. So, and with that, there will be a decreasing availability of informal caregivers, and there is a need for low cost, cost-effective interventions. So, which kind of neatly fits the use of social robots in providing dementia care. Now, what we need to remember is that it's not like robots are going to take over from humans, or robots are going to rule the world or anything like that. It is just that robots can aid or supplement in the routine care of a person with dementia. That's the focus. So these are two papers that I talked about. This was published in the American Journal of Geriatric Psychiatry, and this was just focusing on the acceptability and the adaptation of the hybrid face robot in our setting. It was a qualitative study. And this is a much kind of a longer paper. This mainly looked at how robotic telemedicine can help in overall mental health, and particularly focusing in dementia. And this also had a lot of engineering input from our collaborators in Imperial College London. So I would refer to these two papers. Now, this is the hybrid face robot that we used, which is primarily a tablet, a Microsoft-enabled, Office-enabled tablet, and which had a faceplate. We just used a 3D printer, and which just printed a face, which snugly fits into the tablet computer. And it can be controlled remotely to express these emotions. There are 6 emotions which the robot can show. And as you can see, this is very low cost. You just need a Windows tablet, which kind of cost about less than 20,000 rupees, and a 3-dimensional faceplate, which I think cost about 100 pounds. It was printed in the UK. So roughly it will be about 10,000 rupees here, and a stand for mounting it, which was about another, say, 1,500 rupees. So that's also, you have an overall package in about 30,000 rupees. And this is the hybrid face robot, which if you have one, you can use it with many patients at different times, or even at the same time. So this is something which can potentially be used. It's not very expensive to use. So the methodology that we used was through 5 stages. So 5 stages, as I said, initially we did a scoping review of literature. And as I said, we didn't find that many. And then the next stage was the understanding acceptability and the adaptability. This is the stage that we published in the American Journal of Geriatric Psychiatry. And then we looked at evaluating the recognition of robots' emotive responses. This was an interesting part of the study, wherein we compared how people responded to the emotions that the robots showed. Now, what I need to mention is that this robot was developed in the UK, and we just used it here in India. Now, there were lots of challenges in how people perceived the emotions of the robot. As you can see, the robot has a blue eye, and that's not something which culturally many people liked here, or they related to. So there was some of the feedback that we received was to make it more Indian looking, and make it more relatively real looking. So that was one of the feedbacks that we received initially. I'll talk about that a little later. But this was a very interesting part of the study, wherein we found that there were some challenges in people with dementia recognizing some of the emotions that the robots showed. In fact, that we are writing it up as a paper at this point in time. And then the development of intervention plan, which we already published, and then pilot testing the hybrid face robot. So these were the stages that we used in our study. So this I already talked about. There was very little evidence, and there was, except for one study from Mexico, which used the AVA robot, the human conversational robot. The stage 2, this was the qualitative bit. We conducted a focus group discussion and several in-depth interviews, and we had a person with dementia who participated, along with caregivers of persons with dementia. We had some experts from robotics, both from abroad and also from India. A couple of engineers from CMC Vellore came and participated in the study. And also we had a few professionals from who are experienced in delivering care for dementia. And then we had in-depth interviews with caregivers of persons with dementia and persons with dementia. And we found that caregivers, they were not very hesitant. In fact, one of the interesting things which came up in our initial discussion was the professionals were a little bit hesitant to use the robots, whereas the caregivers were quite okay to try it. And they felt, in fact, caregivers had a lot of suggestions. They said that this could actually reduce some of the burden that they were experiencing, particularly when it came to repetitive questioning that many you must be familiar that many persons with dementia would repeatedly ask about what time it is, or what time it was, or where they were going that day, or if they had if they had their lunch, or what was for lunch, and things like that. So this was something which the caregivers felt this could be potentially used to. And another thing was that the caregivers also felt that the robot should have sufficient artificial intelligence to sustain its own conversation. The way this robot is designed at this point in time is that we are developing in fact, the London team is developing the artificial intelligence. Primarily, there is a therapist who sits in a different room and then makes a conversation which gets kind of conveyed through the robot. And this is something which we were developing the process. We just wanted to see how a person interacts with the robot in front of them. But in the future, going forward, we should have enough artificial intelligence. So if a person with dementia asks the robot, so what is for lunch today, then the message should have been loaded in the system, and the system should say, you're going to have, whatever it is for lunch today. You're going to have sambar rice or biryani or whatever that you're going to have for lunch today. And of course, there were lots of concerns about how secure this was going to be, people going to hack into it, or people going to misuse it and things like that. But of course, there were lots of things which we can potentially do to overcome those problems. And then, as I said before, we wanted to look at how people were able to understand the robotic emotions. There were differences. We used normal human emotive responses, compared it with photographs and the robotic responses, and there were differences between the two. And this was something which came up quite a bit, and this is something which we are going to modify in the next set of studies that we are planning to do. So this was the intervention plan, actually. So we, based on our interviews with the caregivers and our interactions with persons with dementia, the suggestion was that the duration should be just for once a week to try it, to see whether it works or not. If it's more than 30 minutes, if it's more than once a week, it will be difficult for the caregiver to bring the patient to the center, or for the caregiver to spend time sitting with the participant, or helping the participant to engage with the robot and things like that. So this was a trial, initial feasibility study. So one of the suggestions was that it shouldn't be for more than 30 minutes and it should be just for once a week. There are lots of activities which they suggested. One was discussing important headlines, or some interesting reminiscence pieces, like India winning the World Cup in 1983 and then again in 2011, and things like that. People can talk about it, and listening to music, popular film music, or ghazals, or film songs and things like that. And of course, there were lots of other things which they suggested in about how should we introduce a robot to a person with dementia who was not used to technology very much. So lots of kind of suggestions which came about initially to introduce it in steps, ask the patient to touch it, to feel it, and then and have a relative sitting next to them and having a conversation with the relative and things like that. So lots of suggestions which came about, and then of course we kind of did the teleoperation. And the final was the pilot testing, which we tested. Unfortunately, by the time we were doing this, the COVID kicked in, and we couldn't actually we couldn't bring the participants to our center. Now, I wish we had done the study a couple of years earlier. By then, we could have actually used this during the COVID study, but I'm sure this is something which we are planning to do again in the future. And with that one participant that we tried, we really, the participant was quite happy. The caregivers was quite happy. There were a lot of technical glitches that came about. The internet speed was a problem. Sometimes systems tend to hang and things like that. So we actually had to overcome a lot of those issues And I think those were things which we learned during this period, and how, of course, the engineers in the team helped us to overcome some of these problems and see how we can, make this better in the future. So this is the future. So we saw a kind of a tablet computer with a faceplate. Now this is the future. This is called a BrainBot, which is now currently being developed in the UK, and we are going to adapt it for India. And this is relatively easy to adapt, in which there's going to be a human-like face, which again is capable of expressing emotions, and we can change the color of the eyes, the color of the hair, the color of the skin, and all that. You can change from male to female, and things like that. So there will be, it offers us a lot of flexibility. And at the same time, we are going to actually introduce a lot of artificial intelligence into this package, so that it's capable of at least holding some amount of spontaneous conversation with the person with dementia. So that's what we are planning to do in the future. And I'm sure this has a lot of potential impact in the future. So it can actually help a person with dementia, provided we know what the person's interests are. So for example, if someone is interested in cricket, if they're interested in football, if they're interested in movies, we can actually have a pre-loaded information about, say someone likes Rajinikanth movies, and we can actually load information about, we can have a Rajinikanth trivia, you can have Rajinikanth songs, or important clips and things like that. And then that's something which we can reminisce with the person with dementia. We can actually include family albums, holidays, whatever the person's interests are, we can kind of adapt it accordingly. And it should be very easy to adapt if you have the artificial intelligence to go with it. That's something which we are developing right now. It definitely can orient the person with dementia to the time, to the place, to who they are with, where they are, what they are doing. It can remind them about, food, time, if it's time to have their medicines, if time to hydrate. It can actually remind them to go to the dining table and have a glass of water, or it's time for their cup of tea, and it can remind them for their appointments and things like that. And it can all this is to make sure that the person with dementia is independent. Now that's something which it's going to come to us in the future, wherein we are going to have a lot of people with dementia, but not that many caregivers. This is something scenario that we are seeing right now, even in many, and I'm sure it's across India. In many cities, we have elderly living alone, and they have their family either living in the same city or in different cities or even abroad, and they don't have the time or the ability to come and spend time with the person with dementia. Not that they don't want to, it's just that they can't. And this is something which the person with dementia can sustain themselves and be independent for as long as possible, as long as it's safe to do so. And this definitely can monitor for potential risks. If they already, there is a lot of technology. You can pair a lot of existing technology with the artificial intelligence in a robot to alert people if they are falling down, if they are having a high heart rate, if they're not sleeping very well, if they are being a bit restless. All this can be monitored, and information can be stored, and accordingly the robot can respond to the person with dementia in those times. And also monitor for physical health problems, if they're developing fever, if they're having dehydration and things like that, which you can have sensors like smart watches, smart other equipment which they can wear on themselves, wearable technology, and that can actually be linked with the robot and can potentially help prevent a lot of problems. And as I say, this is not something which, even though our work has been limited to dementia, but I think in the future, this has a lot of potential for many other mental health conditions also. So I have to acknowledge my team who have been invaluable in completing many of this work. And this is my email address, and this is my contact details. Please do contact us if you have any questions or queries. Thank you so much for your time and opportunity.
Thank you, sir.
Yeah, there are a few questions, sir, for you. One is that one of the doctors wants to know what's controversial about AVA or AVA, whatever you.
Oh, there's no controversy, so it's conversation.
Okay, fine. And yeah, okay. And also the ethical aspect with regard to robotic use. I mean, are there any issues?
Yeah. I mean, that came up in our qualitative study. There were lots of concerns about How ethical is it to use a robot? Now, one of the things, it's about using any technology as long as it's going to maintain the person's privacy. They're you know, it's not going to share data about the person from outside the trusted network and all that. And of course, there is also the issue of whether the person with dementia is able to consent to use a robot in their day-to-day life. And now, one thing which became very clear was this is not something which I would recommend using for someone with very advanced dementia. This is something which we can use in the mild to moderate stages for people who can still maintain a degree of independence, but with some additional support. I think that's the group that we are targeting, and I'm sure many of them will be able to provide consent for using a robot in their day-to-day lives. So it's, as with using any technology, there are lots of concerns, but these are the main ones that came up in our study.
Well, I will, just pose two questions before you. One is that, do you think that the fact that, we're using robotics now, and probably it will come into vogue in the use of dementia, will it give caregivers a chance to, replace themselves with the robot so that, they get their, one is it would definitely ease their caregiving burden because they wouldn't have to be with the patient throughout. But at the same time, do you think, we're also indirectly removing the human touch which is needed in dementia at times? Does that happen?
Yeah, I mean, that's a concern again which was raised in our study. One of the things is this is not to replace human contact. This is to actually aid or complement whatever existing human contact that is currently available to the person.
Correct.
So this is definitely something which we anticipate will reduce the the stress and the caregiver burden to a significant extent if used correctly. Again, this is not something which you can use for anyone and everyone. You have to select your participants carefully. And of course, you need to kind of adapt the robot for their individual use. It's not like something which you can buy from the market and use it immediately for someone. It has to be introduced in a careful manner, and it has to be programmed in a very specific way for that particular person at a particular time. And so that's something which we probably need to do.
Right. I have another question, sir, that, there's a lot of work done on reminiscence therapy in dementia.
Yes, sir.
And, do you think there would probably come a time where, we could feed, or I would have the robot programmed with, specific reminiscences, which could probably, help the patient sort of recall and even maybe flash pictures and other things, Yeah.
Absolutely. I think that's where I think robotics holds the strongest promise. In fact, there are lots of software. In fact, there's lots of commercial websites which provide. It has a set of questions which you need to answer, and based on those questions, it selects information available on the internet, and it kind of brings together that information and then presents in a coherent way to you, when you can choose whether chronologically or you can choose in whichever way you want the information to be presented, and the program automatically runs the reminiscence session. Unfortunately, it's not available in India. It's available in other countries, wherein most of the information is available on the internet. So whatever it's freely available, you can load it. And you also have the provision of loading, family albums. You can holidays, weddings, and things like that into the system, and then it talks about, oh, this is your daughter, this is your son's wedding, and this is your your holiday in Turkey when you had the best time. And that's something which you can fine tune to that particular person's needs. And I think that's where the robotics holds the the biggest promise. One, in providing companionship, and in providing specific interventions like reminiscence and orienting the person.
Correct. Fine. Okay. Thank you, sir. Thank you so much for an interesting presentation. We now move on to our second speaker, Mr. Rao. Sir, please share your slides and take it from here, and then we'll come back to you later.
Thank you very much, sir, for introducing me. And thank you, Dr. Sridhar and Dr. Padmavati, to giving the opportunity to me to talk to you. Today, I'm going to share you about what telepsychiatry, why telepsychiatry we have started, especially after this tsunami struck in 2004 in India. And 2005, actually, the beginning of 2005 itself, actually, we have just started this. Can you able to see the slides?
Yes, sir.
Yes, yes.
Fully. Yeah, so in 2005 itself, actually, we tried this in Kadalur, Pondicherry, Karaikal, and Nagapattinam. And in fact, we have tried this in actually in, some parts of Kerala also. And we just wanted to we all know that very well about the situation in India, especially mental health professionals in India. There's a lot of scarcity of mental health professionals in India. That in the rural India, it's very less. So though we say that Tamil Nadu is a better state compared to other states, but still in the rural parts, many districts do not have psychiatrists. That's one of the reasons why we started this. Also, we want to just
So
experiment.
just excuse me. You'll have to. So just excuse me. Just make your slide full screen, sir. Yeah.
Yeah, we are just saying that.
Yeah.
Can you see that now?
So never mind. Yeah. Yes. Okay, sir. Yes.
Oh, thank you. Yeah. So in 2005, actually, we tried this after tsunami, and every time, actually, you know very well about it. So, now we have a lot of psychiatrists. In 2005, after the tsunami, we have very less psychiatrists also. And but the need in the Kadalur, Nagapattinam, and all those things was very high. And we definitely want the psychiatrists to go, and also the mental professional, like social workers, psychologists, everyone must be there in the community to give psychological intervention to the people suffering with to people who are survivors of tsunami. And when we take one or two psychiatrists from here, the whole day, the particular psychiatrist will be having some appointments, and the patients who come to see them actually finding disappointment and going back, not seeing the psychiatrist. So we are to reduce that, and we wanted to just try and see actually how this works. So initially, after seeing the patients by psychiatrists in the field, door to door, almost we have seen most of the patients door to door. Around 2,000 patients we saw in the during tsunami. But follow-up visits, actually, we wanted to at least see them through telemedicine. So that's how actually we have started this. I'm sure we all know, but we are very much familiar with the telemedicine now. I don't need to tell anything about that now. Everyone is now almost using this facility, and we are very happy to see that most of them, almost every week, I could see 10 or 15 people actually using our papers as the reference, and they're writing a lot of articles using this, especially after this COVID also. So in 2000, actually 2005, actually 2006, and we almost tried for 5 or 6 years in Kadalur using the telemedicine services, and we saw that a lot of acceptance as well as some kind of actually there is some feedback also as like Steve said, there are sometimes due to the technology, people were saying that clarity of the face is not clear, and people were those days we used to have this small phone. I will be showing that the picture of that video phone shortly, where it will be having a very small this thing, and people from the rural community they are not able to relate to them much. So they have already seen them in person, but when they see them in the video, it is very small like that. People are commenting, and we are we don't know the technology how to do it, but somehow actually some technical person from the local area they said that why don't you connect to the TV, and we could see that the people also were seeing that, and people could able to talk to the psychiatrist who is sitting in Chennai City, and psychiatrists also can 1 or 2 hours they can sit in telepsychiatry and then they can do the other activities in Chennai. So we all know that now actually the kind of it is reduces the time traveled by the professionals, and also they also need not travel long distances. For example, Kadul, if they wanted to come to Chennai, almost actually 5 to 6 hours one way they're taking, and they have to spend a lot of money in the travel, and they have to accompanying person and things like that. But whereas in the telemedicine services, the psychiatrists, they can see them in the local area itself. Of course, there are some clinches in that also. For example, the patient, they are unable to bring the patient to the patient's issues there. And this connection in the initial thing which we have done is using the ISDN connection. So this is advantage of telepsychiatry, using the access to social services and ensure quality of service and enable people to articulate their needs and participate in the interactive sessions with experts all over the globe nowadays. And we tried only with Kotai and the other districts in Tamil Nadu. Enable service provider to be meet to need the specific needs of the individuals. Strengthen the healthcare delivery system, very, very important one actually. And increase the efficacy of service provider, more coverage also increase. Same psychiatrists we used to use for actually 5 or 6 places. The psychiatrist, for example, he actually comes by 9 o'clock. Till 6 o'clock, we used to be using the psychiatrist, and 3 or 4 times, sometimes 5 sites also the psychiatrist used to see. And they had all electronic records available at the head office, that is the central hub at Chennai. Okay, and no traveling and saves a lot of time. Telemedicine will reduce the healthcare cost in long run too. And this is the way actually scope of telemedicine is now. Basically, people can get the data and they can do the diagnosis also. They can take 2 or 3 consultations from other things. And in fact, we had that mission, but we did use the full thing actually. Whereas in other departments like ophthalmology and other things, they used to take used it for something else. For example, taking X-rays, ECGs, and sending information to the other consultants. Also take 1 or 2 or 3 consultation also from there. So telemedicine connectivity, there are many methods are used, and in fact, actually we have used the ISDN connection. This is a triple line ISDN connection initially used. The clarity was very, very nice, but unfortunate thing is that it is available. It was available only in the near to the headquarters, district headquarters hospital or district collector office, and that also not penetrating to the inside the rural area. So that means they have to actually anyway they have to travel 30 or 40 kilometers to come to their telemedicine services. But even then that reduces the cost, but still, people were telling that is also one of the issues they are using it. Now actually later, and then we finding it difficult to get ISDN connection, and then we started using this static IP also, and the broadband connection also we started using it. And now, of course, for the past 6 to 7 years, a lot of technology has changed, and it is user friendly also, and most of the things available in the rural place too. You can see this is the phone I was telling. So this is the phone which we were using in the beginning, and this is where people are saying, oh, that the video, that the face is very small. So then we start connecting to the bigger TV connectivity. Of course, this is the picture we have taken from the internet, but this is not our this thing. So where we have connected this output of this video phone to a bigger TV, so that they can able to relate very well. They can able to see the image of the consultant well, and they were actually doing a better conversation, talking to psychiatrists. Yeah, so we have a database of the patients, waveform analysis. Of course, this is the other piece they're using multimedia files, video conferencing, real-time imaging. There are a lot of advantage of using this and sending some images, taking some X-rays, and these are the, of course, very methods. I'm sure you also know about it. And very many departments are using this. And psychiatry, I think we are the first one in India to use telemedicine in psychiatry. That's how it's called telepsychiatry. Yeah, these are the various technologies, and okay, these are telemedicine activities were started in the year 1999 itself in India, and ISRO started actually deploying SATCOM-based telecommunication network across the country. The initial focus on the government support being in the field of radiology and cardiology and pathology department, and other specialties have been actually neurology and ophthalmology was used. Sometimes, of course, diabetes too. All heavily dependent on the image-based diagnosis. So they were very happy. They were actually transmitting some of the information to the other end, and they were using it well. And we were the first one to introduce these for the psychiatry. Yeah, these are the, yes. So the STEP program. This is a study of telepsychiatry program in Pudukkottai district. That's what's called a STEP program, to provide mental health care in remote areas in Tamil Nadu. As I told you, there are a lot of scarcity of mental professionals in India, and especially in rural India is very, very less. And Pudukkottai is one of the rural districts in India, Tamil Nadu, where it has got a less mental profession. In fact, when we went in 2010, there was only one retired professor was there, and he is retired from government also. There was no public system, so only one private nursing home was there, and many people could not able to travel and could not able to afford to spend so much of money for that. So we wanted to just try and see that district and see how this works well, and we want to reach more people also. Starting mobile telepsychiatry in cleaning the first in the country, and to liaise with the local NGOs. And we also don't want to do it like, staff is coming and doing and going back after that. No, we wanted to actually train the local NGOs who have a like-minded people. They may not be having mental health into that bag, but we wanted to actually just liaison with them, train them, retrain their local NGOs, and be part of it. After we leave, also we expected them to take up this. That's why we call them sustainable methods. We need to have sustainability of the program. So after we go back, that should not actually die. The program should continue. In fact, I think Pudukkottai is still continuing it with some NGOs are taking care of it. Kadalur also is going on, Pudukkottai, Kadalur, and other districts also. It is the NGOs are seeking their. Sometimes they will call SCARF, sometimes they will take the other psychiatrists also who is available there. So as long as the mentally ill person is getting help from psychiatrist, is well and good. So to train NGOs, in fact, actually this mobile telemedicine initially, that the video conferencing equipment we were using for seeing patients, but later we started using it for training the NGOs, training the staff, retraining the staff also. And we want to strengthen the referral system. So we wanted to just not only say, also a psychiatrist there will see that some patient, and some patient they want to refer them onto, they were referring it. Create public awareness using that, empower the families and caregivers. And psychosocial rehabilitation was also used by using this facility. Create standardized methods, also we are using this. So in 2010, expanding the program and coverage, we tried it in Pudukkottai, as I told you, supported by the Tata Trust, and providing mental health services to Pudukkottai district, covering 4 taluks. 2 taluks with actually fixed line clinics, and 6 taluks we want to do 6 areas in 2 taluks we try with the mobile telepsychiatry. So there's a customized bus where it has got actually internet connectivity in the bus, air conditioned and soundproof bus, and that goes to actually, as I told you, there are people who are finding it difficult to travel 30-40 kilometers. We wanted to go to there, reach them, and wherever the signal gets, within 2 or 3 kilometers, they are able to get the signals. Even the same village, they get able to signal, and we are going to the village and connecting the person to the psychiatrist who is sitting in Chennai city. Okay, so this you can see this actually. The down one is the fixed line services where people come to the office and access to the consultant who is sitting in Chennai city, Chennai hub. And the second one is where you can see that this is the central hub. Left one is the central hub at the Ananagar. And other one is the mobile telepsychiatry where inside the bus you can see the regular first image on the top, which is the social worker is actually telling how information is being conveyed by the patients, and everything is being electronically record. So they will also store the information in the electronic medical record that will directly go to the consultant who is sitting in Chennai hub, and they will see, and if they want to talk to the patient, they will talk to them also. If anything they want, any clarification, probably they'll ask the social workers to explain. Yeah. So we were using that as like earlier we used to go and use these training community level workers who are there from that. This is actually very big team we have, and I think we have double that this team right now is available at Pudukkottai now. Okay, and we want to actually just use this. As I told you, getting a mental professional, the role is very, very difficult. Getting social worker, psychologist also. So we train and retrain the community level workers who are hailing from the same locality, so that they know about the jurisdiction well, and they know about the culture and other values of the local people, and so that actually they can able to relate to them also well. So we have recruited such people, and we have trained them, retrained them, and we have taken them to the field, and we have showcased some of the things, and we have educated them also by showing some of the patients in the community itself. So most of the community level workers, what is basic role is awareness creation, identify and refer cases to the telepsychiatric clinics run by staff or any other nearest psychiatric facilities available in government also. We don't want to say that we are only going to have to see the patients. No, wherever is available, we can send them. If there is no psychiatric facility available, we we will be there. Suppose for example, in Pudukkottai, when we went to 2010, there was no psychiatrist. 2015, actually, there was a psychiatrist available, one or two cases, clinic they were seeing. So we don't want to move that. We from that manpower, we have moved to other place, and we have referred all the patients to the nearest psychiatric facility. Supplement the information for diagnosis and management, psychoeducation for the family members is given in periodically. So every Thursday or Friday like that, we used to have psychosocial rehabilitation is very, very important activity. From since after tsunami, actually, we have been doing that at Pudukkottai. Leveraging local resources, employment, referral, we were doing it. Facilitate access to this disability benefits and the Niagara also. Awareness programs connected to the Pudukkottai and screening the cases. At the left, you can see the mobile telepsychiatry bus, and right, you can see that fixed lane psychiatry clinic. So I told you earlier that this is the clinic inside the bus, and this is outside the mobile fixed lane clinic. Yeah, this is right. So inside the after consultation over, they can come out of the bus, and there's a pharmacy unit in the bus itself, and they can come down and then have the medicines and go back. This bus has got as a background, backside actually, and the rear side of the bus has got a big screen. And in the evening, this bus goes to various public places and creates awareness about mental illness and awareness about the telepsychiatric clinics and the dates, time, things like that. Also, contact person name, everything. There's a small documentary about that. We will also distribute some pamphlets after the program gets over. So we were using multiple ways this bus. These are medical records. And we have used to actually send them some messages to them. And again, there's a huge difficulties was there. Of course, there's a lot of legal issues also there. Why? How can we just send a message to someone? Because most of them used to give their numbers of neighbors, and we were just sending them, saying that tomorrow is a clinic, and we will just check whether this person having posting the some phone or at least to the family members. And we were informing them the clinics and updating the status of the patient. Programming the alarm function of the medication appointments, just alarm saying that it's not 2 days a clinic and tomorrow is a clinic like that. In Tamil also there is we used to do it like that. Liaising the local NGOs and government is very important one, as I told you. Transferring our skills and capacity building, introducing key groups, teachers, police, lawyers, media, and that's very, very important one. Working with the GPs and the primary health centers, very, very important one, because they are the big source of referring patients, and they are the one actually who are identifying the patient with the mental illness. So we have done actually many attempts, but sometimes we fail to, because many general physicians are unwilling to attend this training program. Wherever possible, we train these general physicians and the PhD doctors and the nurses also. One is to know about mental illness, and second is to refer them to the nearest psychiatric facility for them to get early attention. Of course, disability groups and disability certificates, we have been doing it. We are also forming self-help groups among the caregivers as well as patients suffering with mental illness. Disability benefits, we are doing it. And benefits of the program, also you can see that a lot of people who are trained were untrained. And of course, we have seen a lot of benefits of using this telepsychiatry. And we have seen actually mobile psychiatric clinic has better coverage than fixed line. But whereas when you see that overall registrations at both the clinics showed no significant difference. Telepsychiatric clinic is 45, 49, and local catchment area coverage calculated, yeah. So effectiveness of clinic was using PAN score was seen, and baseline after 1 year also, you can definitely see a lot of differences after 1 year. We have done actually in 3 talks like that. So cost of service is average cost per patient per month was around 694, and average cost per consultation is 526. This is based only on the recurrent expenditure alone, because the bus alone was costing around 20 lakhs plus. So we didn't include those things. It's only recurring expenditures we have with that. Yeah, those who are younger, marginally better educated, and little less ill are more likely to drop out. Of course, many of you know that the psychiatrists are here in this group. The likelihood of increase when the patient has never come to consultation, yes. So difficulties during implementation was, of course, every program has got some difficulty challenges which we face, and though we say it is one of the iconic program of SCAR, but still we see that there are some challenges which we face during implementation. Sometimes frequent change in staff in the field, because they may get married, they will be pregnant, things like that. Difficulties in identifying suitable local NGOs. Because the moment we ask for NGOs to join hands with us, and people want to know what is their cutting in that, what is their take amount which they wanted to take it from that share which they wanted, and the lack of availability of digital network in very remote areas for telemedicine is finding it very, very difficult. Okay, now of course we getting it with 3G, 4G, and all those. Even 2G getting it for 10 years back was very difficult. The proximity of high cost of VSAT technology for telemedicine. So that's why actually that buses initially we designed only for VSAT, but we could not able to sell it. We thought ISRO will give it free of cost, and we could not able to get it. That's only reason actually we used mobile telepsychiatry, mobile network to use this connectivity. So thank you for your attention. Any questions, please?
Well, if there are any questions, I would request the audience to put it down in the chat box. So I just have only one thing to ask you, that compared to then and now, I mean, when the first tsunami hit and telepsychiatry came into play, and now, do you think there's any change in the acceptability of telepsychiatry compared to, initially when it was used for the first time?
Yeah, definitely, yes. There are a lot of people now in fact, they are very comfortable nowadays. They don't even come to the telepsychiatric clinic. They're telling us now, sir, we don't want to come to the clinic now because we have phone. We don't mind that if you allow us to contact the psychiatrist directly, they're connecting directly.
Right.
And initially, they don't want to see the face of others, and they were very discomfort and were not very clear about. Initially, as I told you, the tsunami started. The psychiatrist already seen them in the field, face to face. After that, only the second consultation, now only actually they happened in the follow-up consultation, only happened in the video thing actually. But nowadays, even the new consultation, first consultation also, they are actually happy to see the psychiatrist in video mode.
Right. Thank you, sir. I don't think we have any questions, so I'll now. I would like to thank, of course, both our speakers for an excellent presentation, an excellent concept that they have put forward. Padmavati ma'am, any comments you would like to make before we hand over to Soumya? Yeah.
It's been a very interesting evening. Although I have listened to both these presentations earlier, it's always wonderful to keep listening to them again and again because new thoughts come in as we hear more about it. Having been part of the entire telepsychiatry unit right from the onset at SCARF, one of the things that which this whole process has enabled, especially across the rural communities. And the important thing to note here is that there has been less dependence on manpower. Right, you do not have to have a mental health a psychiatrist go all the way in person. We also have an excellent liaison with community level workers from the villages where acceptability, I know Rao has already mentioned this, but I would like to reiterate this, that the networking with the community is so critical for such a program. And I think we've been pretty lucky over the years to have a wonderful set. In fact, one of our senior most community level workers has been with us for 30 plus years. As long as SCARF has been, just probably a few years less than what SCARF has been around for. And we must remember that the remuneration is not too high. And in spite of that, their motivation to continue to work has been phenomenal. And I think all these young, now not so young, but when they joined us, they were pretty young. And now, even 3 decades later, they have all continued to remain with the group. And I think that's an important take home lesson because this will help. This can definitely be implemented across the country and will certainly allow more and more people to access mental health services through this technique. Thank you.
Well, thank you, ma'am. There are no questions, so I'll hand over to Soumya. Soumya, would you like to conclude and take it further from there? Yeah.
Sir, I actually have one more question to ask. This is regarding the technology that we are using now. How were you able to convince the patient or the people who's the telepsychiatry?
Sorry, I wasn't able to hear that question very well. I think your voice was cutting off. Could you repeat that question, please? I don't know if that question was to me or to Mr. Rao.
Even I was not able to hear it properly.
Hello?
Are you there?
I think
Hello?
the connection is very bad.
I think there is some internet issue on
Yeah.
our.
What was the question, sir? We were not able to hear it properly. Can anyone hear it properly?
Yeah, even I was not able to hear it properly. Maybe I'll just convey this to Soumya. If she's able to connect it, then maybe
Sure.
we'll.
Am I audible?
That's an echo.
I think you can type that message if it's in question.
I think Soumya is not able to connect.
Okay.
So since we all the speakers so well and explained it so well that maybe a lot of us don't have any questions. So first of all, gratitude to all the speakers and so that they explained it very well and the audience was benefited a lot. So I think we can wind up the session here. And thanks a lot to everyone.
Thanks very much. Thank you.
Thank you. Thank you very much.